Um, so I just, my role here is to give just kind of an overview of the cardiovascular manifestations of MSMDS. And it was great to you know, our first speaker was able to take folks through the basic science. I'm not going to try to do that as much in this talk. I just want to talk about the day-to-day kind of medical things and the challenges that the kids face. So most of you, a lot of you are intimately familiar with this. You know, what are the cardiovascular complications of MSMDS? But for those of you who aren't, you know, as a pediatric cardiologist, we tend to think of things that form in utero or happen just around the time of birth that are, you know, what we call congenital or congenital heart disease. These are cardiac malformations or differences in the heart around the time of birth. And then in heart disease and most of heart disease that we deal with in both children, but even more so in adults, is the acquired forms of heart disease. In MSMDS, we do have acquired heart disease, and that's from a lack of what we call homeostasis, or the ability of the arteries to maintain their job, more or less. So, oh, this is what I was supposed to be advancing through while I was describing that. So what do we see congenital? It's, you know, it's interesting. We saw many patients in clinic yesterday, and one of the most common stories I heard is, you know, almost all the children have a patent ductus, meaning the communication between the aorta and the pulmonary artery, which is supposed to close and is needed for fetal circulation, just doesn't close. But almost all of them told me that their pediatric cardiologist said, well, it's maybe a PDA or it may be a window. I'm not sure. Maybe a PDA, maybe a window. It's kind of largely academic. It causes the same physiology. You know, the interesting thing, the duct is between, like I said, the PA and the aorta is needed and closes. The most common site for an AP window is actually, you know, up in the ascending aorta, but in these children, that's not where it's occurring. You know, it's occurring in the same place as the duct. And because of that, I think many of you have experienced something that's unusual in PDA care, is that they needed open surgery. You know, so most of the time now, and actually for some time, even when I was in training, you know, we've been able to close PDAs with a device, with a catheter. But these kids have a PDA that needs open repair. Some other important manifestations that have been seen is pulmonary hypertension. This comes from more than one cause. You know, we know that there's a congenital lung phenotype that Dr. Kanana will be talking about later that probably influences the ability of the blood to flow through you know, the lungs and cause the pressure on the right side of the heart to be higher. But there's also differences in the arterial bed even before the small vessels that we can see in some of the kids. And then when we think about acquired conditions, these are the ones that we tend to think about, right? So aortic aneurysm or other aneurysm, sort of enlargement of the arteries, and these are the large, what we call the elastic arteries. They're built a little differently. They're also called conduit vessels because they're mostly, your job is to let the blood go through. And then in the smaller arteries, we see stenoses, especially in the intracranial circulation. We also have challenges with low blood pressure and POTS. So I just wanted to give a simple explanation of what most of the children live around, well, just live at a lower pressure, as most of you know. So, you know, an average for a small child, you know, the top number, you know, somewhere from 90 to 100. And most of these kids are in the 70s or 80s, just walking around. And the diastolic pressure is even lower, to the point where probably most of the numbers that people give you with an automated type cuff are, you know, probably pretty inaccurate for the diastolic pressure, but that's a thing we've seen repeatedly. And related to that low pressure is this condition called POTS, and it can affect children and adults in different ways. But the best way to think about it is when you're laying down, your circulatory system has to distribute blood, but it's pretty easy because your whole body's at the same level as your heart. And when you stand up, your cardiovascular system has to undergo a bunch of changes. One of them is that it'll upregulate a little bit of how much blood's coming out of your heart. And that's to keep your brain perfused. It also squeezes the arteries in your legs and the veins in your legs to put more blood flow into circulation, again, to keep blood going to your brain. The basic way to think about POTS is that process just isn't working as well. And it can take time to mobilize that. It can be caused by different causes. In the case of MSMDS, it's because the smooth muscle isn't contracting those arteries and veins correctly. And it can also be caused by collagen problems, that we see in other forms of genetic heart disease. So, Dr. Murdoch talked about aortic disease, and this is certainly not the only place in the circulation that we see aortic enlargement, but it is the most dangerous, and that's the enlargement of the artery right above the heart. It's the most dangerous because it's right next to the heart. And so if you have a tear there that's a consequence of the weakening, it can be life-threatening. And that's why we spend so much time in clinic imaging this area and thinking about it and talking about it, and how much it's grown over a year and so forth. That's my arrow to the aortic enlargement. And then, fairly unique to this condition is that we see stenoses in muscular arteries. There are lots of forms of genetic aortic disease that we don't see this kind of pathology where within the muscular arteries we see proliferation of the smooth muscle cells and narrowing and even slow flow of the blood through that area. And Dr. Murdoch took us through sort of the why and why the cells are behaving that way. So this is the dichotomy that Dr. Milowitz taught me about, which is that, the elastic arteries or the big arteries like the aorta dilate, your carotid arteries dilate, but some of the muscular arteries, like the ones up inside the head, have stenoses, and it's in a stereotypical place, right at the end of the internal carotid. So we also have a mouse. We're learning a lot since the last conference, and I'm not going to take you through it, but I think I do want to play a little video. Let's see. Now. Oh. Wait, how'd you do that? So the little so the Acta2 mouse, it doesn't move as well. It's a little slower. It isn't as exploratory. It's a little smaller, has trouble gaining weight. And this is, I think, a combination of the neurologic function and the cardiovascular function. And we're trying to decipher that right now, but it's similar to sort of the exercise challenges that the kids have. And nicely, they also get aortic and carotid dilation. As Dr. Murdoch was talking about, the intrinsic issue in ACTA disease is a disruption of the cytoskeleton, not just in the alpha smooth muscle actin, but also in the other forms of actin. So it has a sort of what we call a transdominant effect on the entire cytoskeleton, which causes the truncation. And we know that ACTA2 is intimately involved in the process you saw before, which is arterial stenoses. And this is something that has been shown over time by multiple groups and really makes a lot of sense. And we can understand why the arteries are stenosing and try to affect that process. So what do we do clinically about management? There's different modes, and I'm not going to speak to the neurologic care, but just to the cardiovascular care, obviously. One of the fundamental principles of not just MSMDS, but really all genetically triggered arterial disease is imaging. It's the most important thing you do is to go and get regular imaging of the proximal aorta for these conditions. That's because we can do something about it if it gets too big, and if it gets to a risky size. So echocardiography is nice because it's ultrasound and can be deployed without sedation or without putting the child through the tube or the MRI machine. We know the risk of a tear or aortic dissection is proportional to the size of the aorta, and that's why we spend so much time measuring the aorta. We also periodically will do an MRI of the other distribution, so the other arteries peripherally, just to keep an eye, because there is a low but real chance of aneurysms in other territories in this condition. Unfortunately, oftentimes that does require sedation or at least an older child who's cooperative. What about medical therapy as we know it now, not experimental? I think most of us agree that angiotensin receptor blockers, if in the right child and if tolerated, are beneficial. We started this kind of therapy with angiotensin receptor blockers in a different condition called Marfan syndrome, but it was pretty quickly recognized by Dr. Millowitz and other folks who have worked with ACTA2, gene disordered cells, that this pathway is disrupted in those patients, and that we can intervene by giving this medicine. I give, because of the pressure issues in the children, I start the medicine very low and am not aggressive about moving it up, except very slowly over time, because I don't want to, unlike a normal child with high blood pressure, you would just give it all at once, but you don't want to do that in one of these kids. And then if the aorta does grow, we know that we don't have effective medical therapy to prevent aortic growth. We think we can slow it. Is that sometimes surgery is needed. And that is, when you reach a size threshold that's appropriate, replacing that portion of the aorta right above the heart with a Dacron tube will prevent a tear from occurring there. We also do exercise restrictions, mostly just limiting weightlifting, which isn't too big an issue in the children, but there's definitely a lot of discussions about sports and which kinds of sports, and I'm happy to cover that if people have questions later. So, our recommendations are basically frequent imaging in this condition every 6 months, I think is pretty reasonable. And then usually by echocardiogram and then an MRI, if not indicated for other reasons, every several years. Medically, I treat pretty much everybody now with an ARB. Still using losartan, and I can expand on that in the question and answer session. I think we don't know as much about beta blockers and other medicines, but there are theoretical reasons to use one over the other. I think losartan has probably the best risk-benefit ratio. And then surgically, for the most of the children, we've been using a size of 4 centimeters or rapid growth, or if there's moderate or more severe aortic regurgitation, to recommend surgical therapy. It's super complicated in this particular subset of children as when to do this surgery, if needed. because of the neurovascular complications and the neurovascular susceptibility. So really this decision is a difficult one for both parents and physicians, because we're having to trade off risks. Cardiac surgery is safe, but it's not perfectly safe, and it's more risky for these kids than for other kids. So the organ we're trying to preserve is the brain, even though we're operating on the heart. The brain's the most important organ. So happy to engage with anybody's providers. So I'm going to stop there. And always feel free to reach out to me.
I don't need the mic. I can speak up a little bit. Is losartan, is it an ARB or?
Yeah, it's an angiotensin receptor blocker. Sorry. Yep.
I guess my voice ain't loud enough. When they replace the aortic arch, if they use a homograft or they use a synthetic, can the homograft take on the mutation and still enlarge?
So our next session is a recorded video by Dr. Duke Cameron, who's a cardiovascular surgeon. I want you guys to see that, and then we have a Q&A session at the end. I think after seeing that and listening about the techniques, I think I'd be happy to answer. It's a little complicated.
Yeah, sorry, I forgot to mention that we've entered one of these sections. So if we can hold off on the questions until the end of the speakers. This is right now MSMDS fundamentals and Q&A. So at the very end, we'll give a Q&A session for any other questions. All right.
I'm also happy to find you after. Thank you.